may be incompetent or may lack capacity. And we'll talk about the distinction between those two. We'll also talk about what to do in behavioral health emergencies and in long-term commitments. Often the question comes up of, does a patient have capacity to make healthcare decisions, or is a patient incompetent? Those two terms have different meanings. A patient can lack capacity to make a healthcare decision, either a mental health care decision or a medical health care decision, and yet still not be deemed to be incompetent. You will find these definitions in your book, but the question we're going to be dealing with today is really more of having the capacity to make an informed decision in healthcare. And that is a question of capacity. At the time that the decision is to be made, does the patient have the capacity to make that decision? And this fairly long definition covers what the law in Virginia, which is reflected in most states, describes as being required for one to be able to make such decisions. On the other hand, a patient may be deemed to be incapacitated or incompetent. And in that setting, we're usually looking at the long-term situation, someone in a nursing home, someone who's been admitted to an institution, maybe a homeless person. And the question there is for the court to determine, and in the prior discussion of capacity, we were talking about at the bedside. Here we're talking about for a court to make that decision of, does this patient need someone appointed to look after them? Whether that is described as a guardian or a trustee or an executor, an administrator. Lots of different terms are thrown around in various states for that, but it's someone in essence to look after this individual and help them with important decisions. And that may be of two different kinds, and patients have different capacities. A patient may be not able to make healthcare decisions for themselves, but be a savant at math and managing financial affairs and so forth. Quite often, a patient may not be able to manage their affairs. They're up all night shopping on the QVC. They are giving money away at random, and they need help managing their financial affairs. But they may still be able to make decisions about whether they feel ill or need medical care or whatever. In either of those situations, or both, a guardian can be appointed to assist such person. Let's talk about the incapacitated patient, meaning the patient who lacks the ability to make a healthcare decision at the bedside in your hospital setting. We've talked previously about this. The Healthcare Decisions Act, which is enacted in various forms in most states, has a pecking order of who can step in and make decisions for a patient. We've talked about in our end-of-life discussions that pecking order, but for review, it would usually be someone who has been appointed as an agent by the patient before they became incapacitated. Next in line would be their spouse, and then adult children. If there are no adult children, then you would go to any surviving parents. If none of those, then you kind of start going out as if one was inheriting an estate in that pecking order. When no one is available to make healthcare decisions, in the situation of an adult, then you start looking to the social service agencies, such as Adult Protective Services, to look after an individual. And if it is a chronic sort of situation, then again, a court may be appropriate to have a guardian appointed for that individual. The more often situation is a patient comes into the emergency room, they lack capacity to consent, and something needs to be done. Always err on the side of treating a patient. As I've told many students over the years, it is much easier to defend a lack of informed consent case than it is a wrongful death case. A patient's health should never suffer while we wander around looking for someone to make that healthcare decision. An important thing to keep in mind is that a patient always has the right to refuse care if they have capacity. And the question, of course, is just because they make a poor decision do they or do they not have capacity to make that decision? It may be the dumbest decision you've ever seen, but it doesn't mean that they lack the capacity to make that decision. Your challenge is to handle the risk management of that, of when a patient reflects upon what they've done, will they feel the same way? And will their family feel the same way down the road? And so the initial question is, does the patient have capacity to consent? Sometimes that requires a psychiatric evaluation. You may have skilled social workers or others who can help the clinician make that decision as to whether or not the patient has capacity. If they do have capacity, then it's extremely important that it is well documented that the risks, the benefits of care have been explained to the patient, and they have elected not to receive that care. In that situation, when a patient knowingly refuses care, then the hospital, of course, would have no liability for any untoward event that may occur because they have refused that care. Let's turn now to involuntary assessment and treatment, which is, again, often an emergency room issue in many facilities. We have a statute that provides for detention by police officers. We have emergency custody orders, referred to as ECOs. We have temporary detention orders, which are TDOs. So let's go through all three of those in order here. First of all, is the definition of when does someone need or may need involuntary mental health care. That definition has changed from what it was before. The definition now is a little more nuanced, which says that a person who has mental illness and there exists a substantial likelihood that as a result of mental illness, the person will, in the near future, cause serious harm to himself or others. And the healthcare providers can certainly look at what threats have been made by the patient, what their behavior has been recently, and any other factors that may come into that conversation. That is a much more fluid definition than previously. Virginia had previously a standard that required that the patient be in imminent danger to himself or others. Since the Virginia Tech tragedy, the General Assembly has moved to this more squishy sort of definition. Emergent care can be imposed upon a patient also if they are in a situation where they are likely to harm themselves or suffer serious injury because of their mental health disorder. Let's talk now about the detention by a police officer. A police officer is driving down the street, they see an individual and they think, does that person need to be involuntarily admitted or evaluated for involuntary admission? Police officer has a right and ability to pick up that individual if they have probable cause that the patient would meet the criteria for an emergency custody order. And we'll talk about that in just a second. But in essence, they have to have probable cause that this individual meets that definition that we just talked about. They can transport that individual to a facility for evaluation. In most localities, that tends to be the emergency department, but some communities do have a community services board or a mental health authority that has a freestanding sort of facility. The evaluation must be done immediately for the individual. Immediately, of course, is a bit of a term of art. If any of you have ever worked in an emergency department, getting a hold of a psychological evaluator, getting them down to the emergency department, getting everything teed up to get that done may take a while. But it is not allowed to take longer than 4 hours based solely on the police officer's right to detain that individual. An emergency custody order is kind of analogous to an arrest warrant. That order is issued by a magistrate, and the magistrate must have, again, probable cause. Usually that's in the form of an affidavit or testimony by a police officer, by a family member or a friend who says, we believe this individual is in need of emergency care, that they are mentally ill, and that there's a substantial likelihood that they may harm themselves or others because of that mental illness, or they lack the capacity to take care of themselves and they're in danger. Aggressive folks might say that, on a night where it's going to be below zero, a homeless person who is out on the street may meet this criteria. Well, it might not be a wise idea to be out on the street at that temperature, but does that individual suffer a mental illness? That is the pivotal question. And are they in need of hospitalization or treatment for their condition? And are they unwilling or unable to volunteer for the care that they need? If the magistrate finds those things, then he issues or she issues a ECO, gives it to the local sheriff or police officer, who then executes it, which means that they go find the person, pick them up, and return them to a facility for evaluation. That issuance of the ECO and picking up of the individual has to be done within 4 hours after the ECO is issued. Again, the individual has to be immediately evaluated and cannot be held for more than 4 hours under the ECO, even though there is the ability to extend that for another 2 hours if there's good cause of availability of an evaluator. The evaluation is taking longer than anticipated. The patient is not cooperating, whatever that criteria may be. During that ECO period, or under the detention by a police officer, what the issue is that's being evaluated is, does the patient meet the criteria for a temporary detention order, which would allow a longer holding of that individual. Again, the magistrate would issue a temporary detention order, and a hearing is held for that, and the patient has a right to appeal. And we'll talk about all three of those elements in a moment. First is, what's the magistrate looking for? What is the determination that she must make in issuing a TDO? Well, is the person mentally ill? And is the person in need of hospitalization? And is there a substantial likelihood of, because of the mental illness, the patient in the near future will harm himself or others? If the patient meets that criteria during a hearing held by a magistrate on a TDO, the magistrate is again looking for the same criteria that they were for an ECO, but if they find that there is probable cause that a patient meets the criteria for involuntary care, then the magistrate must issue the TDO. That was changed from a may or permissive statute after the Virginia Tech crisis or tragedy. This has a 24-hour shelf life on it, meaning that it has to be served on the patient, and the patient has to be picked up within 24 hours. They are to be held preferentially at a hospital or other facility for evaluation, and a hearing is to be held to see whether or not the patient meets the TDO criteria. They can be held for up to 48 hours, maybe longer over the weekend, during which time they're evaluated. That evaluation is as to whether or not they need involuntary admission to a mental health care facility. There is a hearing to be held on the involuntary commitment proceeding, and notice has to be given to the patient that 48 hours that they be given the right to hearing, the right to counsel, right to be present during the hearing, and to participate in that hearing. The judge would, or the magistrate would consider evidence at that juncture. That would include the evaluator's report, which is done usually during the TDO process, and they are looking for, is there an imminent danger or substantially, well, actually the imminent danger is the old standard, but is there significant risk of this patient because of their mental illness harming themselves or others in the short term? And do they require involuntary admission, or would a lesser, even an outpatient treatment situation be better? They're also looking for the Community Service Board report, which is a second evaluator who's looking at this individual. If a patient is involuntarily committed, they can be admitted for as long as 180 days um, under this criteria, which is that there's a substantial likelihood of serious harm or inability to care for themselves, and there's no suitable alternative to them being treated as an inpatient. A judge can order that a patient be enrolled in outpatient treatment if that's recommended by the CSB. However, if they fail in the outpatient treatment, then that can be used as evidence in a subsequent hearing for the involuntary admission. If a patient does not agree with the involuntary admission order, then she or he can appeal that to the circuit court judge. And again, a trial is held, it's referred to as a de novo hearing, meaning that it is all the evidence is considered fresh. Whatever the ruling was previously is not considered. And except for the fact the judge can simply admit the evaluator's report from the underlying admission hearing without calling that individual again, or that he or she, the judge, can request a new evaluation to be performed. Once the patient is delivered to a psychiatric facility, the patient must again be evaluated by a physician at the facility to determine whether or not they meet criteria or appropriateness for involuntary admission. Sometimes patients arrive and the hospital doesn't agree that this person needs to be a patient at the facility. If that's the case, then the sheriff or whoever brought them has to take them back home and release them at that juncture. Challenging questions that present themselves in a mental health care facility often center around informed consent and treatment of individuals who are involuntarily committed. For example, can a patient be required to take medications? That is subject of ongoing ethical and legal debate as to whether you can medicate someone well enough to have them face criminal charges, whether an inmate at a facility is required to take medications, and if so, to what level? Is that to one of passivity, like the old days where we medicated all of our patients in kind of a stupor, or is it just mildly imbalanced? Certainly there are very strong limits on what's referred to as aversion therapy. And I'll let your peers who've taken psychology talk with you about what aversion therapy is, but think cattle prod, that sort of thing, to get people to do what you want them to do. Another hot topic in behavioral health is electroconvulsive therapy. Most of you, I'm sure, are too young to remember the movie with Jack Nicholson called One Flew Over a Cuckoo's Nest. But it demonstrated the bad old days of ECT, where patients were often rendered totally incapable of doing much of anything after ECT. Modern ECT is much less destructive to individuals and is very well tolerated and is very much back in favor. And so again, the question, though, becomes if a patient is so grossly depressed or whatever the condition is for which ECT is indicated, how do you go about securing consent for such an individual? Most states require a great deal of precautions, such as a second psychologist or psychiatrist to confirm that that's the appropriate course of care, that the care is being monitored to assure as much safety as possible for the individual. But all of these are very hot topics continuing to this day as to how we take care of those who suffer from behavioral health issues. That's the end of the kind of the highlights of the mental health decision-making unit. This good-looking guy is my old dog. This is Rux, R-U-X, who is now 13 years old plus. He has some cataracts and doesn't hear so well, but he's still hanging in there. Thank you all for listening.